legitimate spermatic cord upper. Like it's the wrong location.
Yeah, the main difference is the site. So sperm granulomas, okay, the legitimacy. Okay, this first difference. Okay. It's also slightly different in that with fasciitis nodosa, of which this is, you can get regeneration of those first difference, which I'm trying to look now. I can't see them. I'm sure they're there somewhere. You can get these small regenerative small ductules that are forming. Because remember, this occurs in the setting of vasectomy, and it can try to recanalize. So you can get these ductular structures, which for some people might look like an adenocarcinoma. We've got some examples here. See how we've got those roundish structures there. Okay. Some people have seen that and thought maybe that was those were malignant ductular structures there, but they are not. One of the clues is having all these spermatozoa in those ductular structures and around them. Okay, if it's an adenocarcinoma, because you can get an adenocarcinoma of the first difference or something metastasizing from elsewhere, it doesn't come with those spermatozoa and spermatids that you see in the background. And like I said, a lot of these cells are histiocytic, they're plump histiocytes, and you can prove that by doing histiocytic markers such as CD68. Those structures there. So that's fasciitis nodosa. You can get something similar in women as well, the fallopian tube, what you call that?
Salpingitis is not going to do that?
Yeah, salpingitis is ischemic nodosa. Yeah, but it's exactly the same kind of histology and setting of tubal ligation in women. Okay, that's straightforward, benign thing. As long as you recognize that this wasn't malignant, might worry with some people, but if you code it malignant or give a degree of malignancy there, you're in trouble. Okay. Second one. So what's your name? Jean. Yeah. What did you think of this one?
So actually I was a bit worried.
Then you were not worried.
Yeah. Still worried. So pieces of fragments of tissue with non-keratinizing squamous mucosa on it. So some sections with widespread acute inflammatory cells, neutrophils and eosinophils. What caught my eye was the multinucleated cells around this area. It's a bit of a different orientation. With the glassy intranuclear inclusions. So I immediately thought about infection for one. And there was like a blister occurring, possible blister occurring, separation of the epithelial layer. So I favored HSV for the differentials and substitute a HSV stain. For the mucosa, the squamous layer looked a bit reactive, but I couldn't pick out any malignancies, so I kind of stopped that. Just favoring HSV infection.
Yeah, you need to be more committal than that. So if you say, oh, my differential was HSV, the moment you use the D word, I'm expecting another diagnosis. If that's the only one you have, just call it HSV. Move on. Yeah. So HSV yeah. So it's not. Don't always feel like you have to give DDs every time and you non-committal and all that. Okay. Particularly in your part one, probably out of those 20 cases, 15 to 18, we should be able to call them out right without having to give a because it's classic features will all be there, and you should be able to call it outright. Okay, so more confidence. HVC, there's ulceration, keratinizing stratified squamous mucosa with glass inclusions of HPV and so forth. This is the immunohistochemistry for this case. Yeah, so that's the more. So yeah, going HPV. All right. So the point there was to make sure that attention to detail. You're looking at your slide currently, so you can see one or two of those cells with viral changes. Okay. Sarah,
Yes.
what did you call number 3?
I am calling it encapsulated fat necrosis. I wasn't sure whether that or I'm calling it torted okay with the location being sigmoid nodule, but I didn't see anything malignant on my own view. But could be very wrong.
No differentials. That's good. Okay. Anyone got otherwise?
Oh, yeah, I was worried about lobular.
About lobular breast.
Yeah.
Okay. Where?
There's just inflammatory cells that are lined up in one or two places.
So inflammatory cells make you worry for lobular. How?
Well, it can look like inflammatory cells when it's grade 1. I've got no history in this case, so the ovarian mass could have been a met. I think it's not a morphological sure bet, but I'd do a keratin stain in the absence of any history.
Lobular. Okay. No, there isn't then.
Yeah.
So just inflammatory cells, and you've got hemosiderin pigment and cholesterol clefting, bit of a Jack-cell reaction here. So when you see those sort of things, you should be reassured that you're in the presence of reactive and regenerative changes. Okay. Yeah. So Sarah, you are right. This is fat necrosis here, and what was the history?
72
Yeah, sigmoid. So it's a nodule that's attached to the sigmoid. So yes, you should be able to. You should call it a trotted appendix epiploica. Okay. Bit of calcification here. All this fat necrosis and some reactive changes. There's nothing to worry about malignancy there. Now, again, this is one of those examples of things that are benign and not too worrying that you'll see on day-to-day sign out, but people wouldn't bother actually putting them in as like that. And this was actually taken out for a good reason by a clinician who's worried about metastasis. Okay, so laparotomy, ovarian cancer, then they see a tiny nodule. Then they wonder whether the tumor has already spread to the colon in the peritoneum. So they would take that nodule either as a frozen section or send it for histopathology. So it's important to let them know that no, it's not malignancy. It's just an epiploic appendage. Okay. Any questions there? Yep.
I called it a calcified fibrous tumor. Is that? Like a peritoneal nodule, very calcified.
I can see why you're saying that, but it's not. Okay? It's got reactive changes in there. It's got fat necrosis. Calcifying fibrous tumor doesn't have fat to start with. It's really fibrous. It's really sclerotic in the stroma. It does have a bit of, scattered foci of calcifications and a bit of inflammation. It tends to be attached to the peritoneum, that's right. But yeah, it's just not, it doesn't come with those reactive changes and the fat necrosis. So depends on how the examiner would approach it, whether they would give you like a borderline or something, because it's a good thought, but no. All right. Any other questions? Yeah, so toted epithelial appendage, just something out of routine day-to-day sign out. Number 4. Rob.
Yeah, so this is a very busy slide. There's a lot of pieces of tissue, highly cellular. So I think there was areas where there was some urothelium as well. But overall, I thought there was a typical infiltrate. There was both sort of epithelioid and sort of signet ring cells. And some of them look sort of like sheeted and cord-like arrangement. I couldn't see any obvious glandular architecture. So I thought this was probably malignant. Although I didn't see any in situ disease, and I favoured like an invasive urothelial carcinoma. DD like a metastatic carcinoma, like signet rings. It had signet rings like gastric or colorectal. Given it was also a woman, so I also considered like metastatic breast cancer.
So what made you go down the route of carcinomas? Because you've listed several carcinomas there, right?
Yeah.
What's there to make it a carcinoma?
Oh, I thought that was epithelial itself.
Where?
In the tissue.
Where?
But I mean, it's a lot of faces.
Yeah, no. Can you show me any carcinoma glandular or?
Yes, I didn't see any glandular.
Urothelia or anything that that made you think of carcinoma?
Yeah, so I didn't see any glandular stuff. But I guess from like a carcinoma, adenocarcinoma, I thought there were like signet ring sort of cells. But I mean, I was looking at the scan slide. But there was like
that's not an excuse. Don't
Sarcoma.
give me excuses. The exam will be, digital.
Yeah.
Unfortunately. Oh, okay. I'm looking very hard. I can't see anything that would make me think carcinoma at all. You're right that it's busy. There's a lot of things happening there, but it's mostly these spindle cells, isn't it? It's fascicular in areas, plump in others. Not sure what's happening here, but there's a blood vessel in the middle and sort of breaking apart a bit, but not really glandular. What did others think?
There was a focus of pigmentation.
Yeah.
Like the second from the right on the bottom piece.
Yeah, there was.
That's the only bit I saw.
There was. I'm trying to look for it now. I can find it. But yes, there was a bit of pigment, which was the blue.
Yeah, I favoured the aesthetic.
Yeah, bottom toward the right.
That bottom middle.
Like here.
No, it's in one of the darker fragments.
I'm not sure which way it's oriented on the digital.
Yeah, the one that I had, in fact, I marked it. Then I had to remove the thing for scanning. So now I've lost it. But right. So what did you think, Sarah?
I have melanoma.
But that's not the one.
Oh, that looks better.
Yeah, it was really
Yeah, that was-
clear in one spot.
Yeah, no, it is there. Because when I actually reported this, that's what led me to the diagnosis. Probably to have thought of melanoma in this case. And this turned out to be. Yeah,
Yeah.
There it is.
yeah, that's the one.
I thought that was human cigarette. Because on the glass light you can't flick the condenser.
Imagine trying doing it.
Yeah, it's like there's no.
Yeah, but remember, if it's hemocitrin, it has to come with histiocytes. It will be in histiocytes, not in the tumor cells, in the spindle cells. That's what makes it different.
I see.
So this was a difficult one. Don't feel too bad if you got it wrong. But the whole idea was to, get you to think outside the box and come up with DDs. And if your differentials include melanoma somewhere, then you should be able to get a pass. Okay? Because there's a lot of differentials here, like sarcomatoid, urothelial carcinoma. When I saw it myself initially, I was thinking of things like synovial sac and solitary fibrous tumor, malignant type, and so forth, because that's what those fascicules look like to me. I only did melanocytic markers because of that bit of treatment there. So this is HMP45 and plus 100, which all melanocytic markers were diffusely presented here. So it is a melanoma. Take-home message being always think of melanoma in things that look poorly differentiated or undifferentiated. Melanoma probably has to be at the back of your mind always. Does both in exam sequence. I think in my part 2 exam there was a melanoma somewhere. So always think about it. Okay. Any questions?
I still had like I favoured melanoma, but I still had a big DD with a big table because I felt like it could be anything.
How many DDs did you
Well, that's
give?
the thing. They say like, oh, you can't have more than 3 or 4, but I think I put like 5.
Okay, let's
But I still
hear your
favoured
DDs.
melanoma.
I mean, if they're reasonable DDs, we gotta give it to you.
Oh well, it's just
what were they?
unsure the more I kept writing. Because I was like, they don't like this, but.
Yeah, let's hear your 5. Your 5
Well, I
DDs.
said like favor melanoma, then sarcomatoid urothelial, but there was no in situ.
Mhm.
I had synovial sarc and leiomyosarc, and then like a malignant SFT, and then like a rhabdomyosarc.
Yeah, sounds reasonable. That's
Yeah, well,
those
I just felt the more I was
DDs,
writing.
when I saw this initially, so I kind of I have to agree.
Okay.
Yeah, because it's got some areas where it gets really spindly and very cellular, dense, and those fascicles, and you start to think of synovial sac.
Yeah, I just didn't know whether I should stop.
Yeah, you probably want to trim them a bit and go for your best 3.
Even because I'm just
Yeah, but it's a hard one. I have, it is as difficult as to get. This should have been in part 2, but you have to come up with a plan. You have to show a plan and to show me some DDs, one of which includes metastatic melanoma. Then you're like, yeah, you pass. Yeah, you can't call it outright. Okay. Right, number 5. What's your name?
Johnson.
Johnson. Yeah,
Uh,
Dennis Johnson.
this prompt was a 35-week termination of pregnancy for anhydramnios. So when I looked at it without looking at the prompt, it kind of looked like immature kidney in a way. It's got these small glomeruli, immature glomeruli, kind of bundles of cartilage as well, and kind of a haphazardly spaced. So but then I saw the prompt, it didn't really make sense to me, but I thought it was like a renal dysplasia, a congenital renal dysplasia of the kidney. in the section.
Okay. Yeah, that's correct. What are the other features of cystic dysplasia?
So you have abnormal architecture, you have cartilage, I think you can have smooth muscle concentric around globules and nephrons, I think, but that's what I have. Oh, sometimes if it's cystic, you can have large cyst formation.
Yeah, you can have cyst and duct-like structures, tubular structures, yeah. So the dysplasia part comes in because it's all disorganized.
Yes.
Okay, so you get tubules and a few abnormal glomeruli intermixed together. Then the stroma is sort of mesenchymal, so you get this immature stroma in the background, which even if it's cystic dysplasia in a pediatric patient, it will still look primitive like this. Okay, might get this onion ringing around some of the ductular structures. But the giveaway, at least for this slide, is the presence of cartilage. Because there's no place for cartilage next to glomeruli in a kidney. A normal kidney doesn't have cartilage. So the moment you see cartilage, cystic dysplasia, if you didn't have that, then you'd probably struggle going down the route of several other DDs of kidney disease. But this is probably the only vision where you see cartilage in the kidney with primitive mesenchyme, so renal cystic dysplasia or renal dysplasia. Okay, I think you can call it outright. I don't have any DDs. I don't know whether I've got any differentials. Those differentials.
I was thinking it could be a Wilms tumor, but I wasn't really sure what it was.
Wilms tumor.
Or Wilms tumor.
Wilms tumor.
Yeah.
Which one? Which subtype?
Nephrophus.
It's not. No. See, there's glomeruli everywhere. So if there was a tumor there, it would be mass occupying, it would push everything away. So the fact that there's a lot of things mixed in there just tells you that you're not dealing with a neoplasm, a mass-forming neoplasm. It's just this kidney that is abnormal in architecture, where everything is just jumbled up and all mixed up. So no, I wouldn't entertain Wilms tumor in this instance. If maybe it was mesenchyme twitch, where there's like a large area, an expansile area of mesenchyme, then you think, oh, maybe it's one of the subtypes, like a monophasic worms, then I would agree, but not on this one, not best of this one. Yeah, is that fair? Yeah. So a little bit pediatric, but still diagnosable.
Did you say renal dysplasia or did you say cystic renal dysplasia? Wasn't there any?
It's the same entity. It can be cystic in some areas. In some situations, it can just be dysplasia without the cystic appearance, but it's an alternative name. Yeah, I don't. I've heard people saying the examiners these days were going a bit crazy with terminology. I think both terms should be acceptable if I was the examiner. What about this one here? What's your name?
Shiva.
Shiva. Yeah. What did you think?
I thought this was a dermatofibrosarcoma pituitarians.
Why?
So it's a densely cellular dermal-based lesion with a storiform or cartwheeling pattern. There's also honeycombing and fat entrapment. And there's no brain, like nuclear mitosis.
straight up, or gonna give DDs?
You could have DDs of other
No.
speakers.
You tell me, do you want to give DDs or do you want to call it DFSP full stop?
I wanted to call it full stop.
It's fine. It's good.
Okay.
I'll call it DFSP. Don't have a differential. Yeah. We're trying to move away from this thing of like, for every case, maybe it could be this, it could be that. You don't have to do that all the time, okay? If you're convinced and all the histopathological features are there, just call it outright and move on with confidence. Yeah. All right. So for me, it's got all the features of DFSP. I don't have a DD. I'm not going to go down the route of, it could be a DF, whatnot. No, it's just story form pattern everywhere. This amount of story form pattern, you don't find it in DFSP. It's going into fat, those plump spindle cells, and you don't inflammatory histiocytes in the background. Here it's getting a bit myxoidy stromal appearance. DFSP, you can undergo sarcomatoid transformation, which this one doesn't have, but that's something to be aware of as well. But you can have a focus at the base where it just becomes very malignant with lots of mitosis and necrosis and so forth. And you can say it's a DFSP with fibrosarcomatous transformation. That wasn't the case here. All right. Any questions? Any concerns? No? Everyone went DFSP outright? I hope. Sorry, what's your name again?
I'm Ali.
Ali. Yeah. So what did you call this one?
So this is a section of prostate, and there were these large glands with cribriform structures and clear cells, but on higher power I thought I could see basal cells, and I didn't have any nuclear cytoplasmic features of adenocarcinoma, so I called it clear cell cribriform hyperplasia, but I said I could do a PIN4 to confirm my diagnosis.
And what's this? Are
I
you
thought
worried
that
about
one
this?
might be like some of the urethra or like central area. I didn't look at that part of
Yeah, it's a Seminole Vesicle.
Okay.
Okay, it's Seminole Vesicle, and can give, they sometimes bring this in core biopsy, the biopsy exam, just this. So you shouldn't call it malignant. So there's a Seminole Vesicle there. And yeah, I agree. This is cribriform hyperplasia. Okay. Again, one of those benign things that we're trying to catch anyone who calls this adenocarcinoma cribriform pattern. Therefore, this on score 4+4. If you do that, your head can chop off. All right, but it's all benign. You should be able to appreciate that these acini, they've got corporal amylasia, they've got ample cytoplasm, lower NC ratio, and more importantly, the basal layer of cells around those acini is present, it's intact, therefore it's benign, it's completely benign, and across benign acini can have this cribriform pattern, it's totally acceptable. Okay, that's the catch there.
And I took a pretty quick through. What if I just called it benign prostate glands and seminal vesicle? That's
Yeah,
good.
that's fine.
You don't have to specifically say.
Yeah, it's fine,
Yeah.
but this lesion has a name, so
Yeah.
if you look in the book, it's called cribriform hyperplasia. And the only reason for doing that is,
It's a mimic.
so you can identify it's a mimic of cancer. Yes, you're right. Yeah, if you just go benign, you can do that. Well,
They might borderline you potentially, based off other things. When you call benign, like cancer tumor, that's a borderline.
Right.
You have to say what.
What was that?
Oh, in like last year, like you said, like borderline, like benign next tumor, you get a borderline.
Oh yeah, they want
So
you to specify.
they might want you to specify.
Yeah, I mean, it's good practice that if something has a name, give it the name, say what it is, don't just say benign or malignant and that sort of thing. Sounds reasonable to me, because we want to see that you've actually read something and know something. Yeah.
Yeah, so this is a salivary gland, so we've got lesional tissue here, but the cells are quite large. Some of them had vacuolated cytoplasm with like basophilic granules. And then the nuclei are quite small and have stippled chromatin. So I was thinking this is an acidic cell carcinoma. And you can highlight the zymogen granules by doing a PAS-D, and acidic cell carcinoma is positive for SOX10 and DOG1.
SOX10 and DOG1.
Yes.
Now, if you SOX10 and then DOG1, before I do that, we'll give you the PAS. How do you interpret that?
Actually, like that dense, like magenta stuff, I thought was zymogen granules, but you have to look a bit closer into the cytoplasm, I think.
I think there's page positivity. Some of these areas here.
Yeah.
Okay. DOG1. What say you?
Positive.
Positive. So S100. It's got patchy positivity there, but I agree. It's arsenic cell carcinoma. Again, even without immunos, I think you should be able to call this outright. So salivary gland tumors are, good fodder for exams. So if towards the end and you want nothing to do, or you want to bump up your mark, probably finish with salivary gland tumors. They're characteristic and diagnosable just on the pattern alone. So it's they feature in exams quite frequently there. What do we know about arsenic cell carcinoma? Any something you'd like to share?
I don't know, I think molecular is like NR4A3 mutation. It mainly occurs in the product, I think. Yeah.
The other thing is, this is probably the most characteristic appearance, isn't it? But they can come in different patterns as well. So some of them can really be solid or papillary cystic. They can have microcystic appearance. And the cells, if they're serous arsina with those basophilic granules there, then it's very hard to pick. But some of them can be clear cells or a bit vacuolated and so forth. That's when it gets a bit difficult. So it's good to see the broad spectrum of arsenic cell carcinomas, because they can be slightly different. Yeah. Any questions? Any comments?
If you gave a differential but favored acidic cell with the IHC, would that
What
would
would
be
be your other differentials just to be reasonable though? So what
Right.
are your DDs?
Well, I thought I saw some mucinous cytoplasm in some of the background, so I said mucoepidermal as a differential.
Okay. Which one did you favor?
Acidic.
Acidic, yeah. I didn't see any mucin there. If it is, it will be very focal. Would that be acceptable? I'm not sure. I don't know. It just doesn't look like anything to me. Yeah, when you see that basophilic appearance with those granules in the cytoplasm, these large cells and that sort of thing, I can't go past arsenic to look for something else.
Okay.
Yeah. But maybe they'll give it to you if arsenic is your favorite one. But again, it's one of those where you just don't want to give DDs unnecessarily. Okay.
I think you skipped one.
Let's
Thank
skip
you.
one. Let's skip 9. Right, thank you. Right. So, Sarah, what did you call this one?
Without reading the stem, I thought it was fibrous hematoma of infancy, without thinking much about the stem. But then I got confused with the age because I feel like I've been told it has to be under the age of 2, and this was a 4-year-old. So in terms of why I thought that, there was some mature adipose tissue, there were some differentiated spinocerebellar areas, and then some areas that looked a bit more pale and immature. But yes, then I got fuddled and confused with the age, but I still favoured that, and I thought perhaps if it's for a differential in a bit of older patients, I could think about a spindle cell lipoma, Pneumonia CD34, but yeah, I ended up sticking with the FHI.
So you think a spindle cell lipoma will be more acceptable in a 4-year?
Yeah, still 4 is still younger, but I didn't have anything for the in-between age.
Yeah. I mean, it's, yes, textbooks will say usually under the age of 2, and maybe 40% of them they are congenital, so these kids are born with it. But that's statistical.
Yeah, there's always
3-4-year-old, yeah, there will always be some. So don't get hung up on just one thing on history. The morphology is very characteristic here. Okay. It's a triphasic tumor. What are the 3 components?
Yeah, so the mature fat, the differentiated spindle cells, and immature mesenchyme.
Yeah, so mature fat, and then you get 2 spindle cell components. One looks immature and mesenchyme, and the other one looks a bit more mature. You can sort of see it here as well, that you've got some areas that look a bit pinker, which are the more mature areas, and then some areas look a bit more immature. The spindle cells are much, they're a little bit plumper. Okay, they don't look like your usual fibroblast, whereas these ones here do, they look much pinker and more mature looking. Okay, so it's that biphasic appearance there, that triphasic, sorry, which is the giveaway. Lots of fat, which can make it very difficult to tell the margin sometimes where it starts or stops. This one seems to be transected at the margin here and focally going into fat, but this lesion is completely benign. In terms of does immunohistochemistry help?
I have read about BCL2 possibly being positive in the immature component, but I haven't seen it in the lab. SMA in the fibroblastic areas. I think morphologically.
Yeah, it's pretty much morphology. SMA will highlight the more differentiated spindle cell component, but not the mesenchymal bit. I think I did it here. It wasn't very helpful. Doesn't really add anything. So again, this is all pure morphology.
Given the age and the amount of fat, can you consider lipoblastoma? Because that has immature mesenchyme as well, I thought.
Yeah, but then there are no lipoblasts there. This is mature fat.
But
Yeah,
You don't-
lipoblasts look very different.
yeah. But I've seen a case where you don't have to have like
I have to see at least a lipoblast somewhere. You know, lipoblastomas. Yeah. No, the fat is different.
Okay.
Yeah. This is very, very mature. That it didn't even cross my mind at all.
Oh, yep, that's fine.
Yeah. No, it's this is very, very mature. Adipose tissue. I don't see anything that would make me think of lipoblastoma here. I mean, I can see what you're doing here, going down your list of, pediatric adipocytic tumors and that sort of thing, but nah. Those ones has got slight variation there, but geez, nah. Yeah, I think you've got, for something that's triphasic and everything is there, you've got to call this one outright if you know about the entity. All right?
Yep.
Shiva, what did you call this one?
So you've got a circumscribed nodule with a sieve-like architecture composed of, spaces, like sieve-like spaces. So I said that it was consistent with an adenomatoid tumor.
Why using the word consistent with?
So the appearance is consistent.
Yeah. Just say it's an adenomatoid tumor. What's like consistent with or in keeping with? They've got a place. It's something that I would probably say if the clinician told me it was this or they're querying this, and maybe I don't have enough histopathological features to call it that, but it looks like it fits, then I'll say, yeah, this is in keeping with whatever you told me, because that's what you told me. Here just said outright, so this is an adenomatoid tumor, full stop. Show some confidence. Yeah?
Yeah.
It's an adenomatoid tumor. All right. This muscular-like structures, mesothelial cells that are flattened, usual location for where you do find this tumor in the uterus mass forming, and things that are a little bit more unique, like having these thread-like bridging strands that cross the lumen of those ductular structures. It's very characteristic of adenomatoid tumor. It's almost always present in every case if you look hard enough. If you're going to do immunohistochemistry, not that you have to, what do you expect this tumor to stain with?
A positive for mesothelial markers like DKL-RET or CK56. WT1.
Yeah, one of those. I've got a cow red here that someone did, and that thing is lighting up. Okay, which tells you that it's not vascular. It's positive for cow red, not vascular markers. You want to confirm, but you don't have to. So you could mention some of these immunos in passing in your description if you wanted to. Just to show that you know about it, but you should be able to call it outright. Any questions there? Nice and straightforward. Something from your daily sign out.
Yeah, that's very good. I think this was a female elbow or something. Sections of soft tissue with kind of large areas of necrobiosis and
There's a
surrounding.
foot joint actually swollen.
Oh, foot, yeah. Surrounding like palisading histiocytes. So I thought this was good for a rheumatoid nodule.
Okay. Differentials?
No, I think in the exam you'd have to say that you'd do bug stains.
This was an exam, Anna.
I think I did say that.
Okay. Yeah, so yeah, I would say it's necrobiosis.
Yeah.
Not
necrotic.
Yeah, I think this clinical seeking it's rheumatoid nodule. Any DDs? Because there are other things that can give you similar necrobiosis.
Yeah, I think if it was in the skin, it's like granuloma annulare.
Yeah.
necrobiosis.
Deep granuloma annulare as well.
Yeah,
Yeah,
that's
just
true.
look like that. It's
Yeah.
it's mostly possible to tell them apart. Anything
True.
else?
I like necrobiosis that would occur, but again, it's not the right setting.
Yeah.
Epithelioid sarcoma.
Yeah. But, instead of histiocytes, you have the malignant cells around that area of necrosis there. So, yeah, necrobiosis will give you the rheumatoid nodule, and that site and location and everything. Okay. Nice and straightforward. Everyone happy? What do you say there? Rob.
Yeah, so I think this one was 12, so 73 male, 3 centimeter mass. So I think if you look at the outside, it's like the adrenal gland, you can see adrenal cortex. And then in the sort of replacing the medulla, you can see this sort of tumor that has sort of Zalbolan architecture with sort of syncytial sort of cells, and then a sort of vascularized sort of trauma. I don't think there was any like sheeting or vascular or capsular invasion. Mitosis were minimal. City necrosis, significant pleomorphism. I call this a pheochromocytoma. And then I'll do like SDHB to screen for like SDH deficiency and do like a formal PADS score.
Okay. Yeah, no, that's correct. It's a pheochromocytoma. Right location, the amphiphilic look, the cytology, the cell pattern appearance is not obvious except in some foci there, but it up it's immunochemistry. SDH, that's correct. Does it have prognostic significance if it's SDH deficient? Does that matter?
Well, it's got if they have like a germline SDH deficiency, it would predispose them to, various tumors. May carry significance in terms of that, but I don't think I'm not sure from a pheochromocytoma point of view. I don't think so. Not sure.
So the fields associated with SDHB are more likely to misbehave, more likely to develop malignant fasting size and cause trouble. Yeah. So we'll talk of 30% risk of metastasis and so forth if they're SDH deficient. Any comments there? Anything to mention? I think that was a giveaway. It's easy. Jones?
Number 13. So
Yeah.
34-year-old male paratesticular nodule on ultrasound. So we've got this circumscribed lesion surrounded by adipose tissue. It's got a bit of a weird architecture in areas, but focally towards one end looks like adrenal gland or adrenal tissue. So I called it ectopic adrenal rest or ectopic adrenal tissue.
Looks like adrenal gland in what way?
It's got that kind of stratified look. It's got that central nuclei with some clearing in the areas here. I did think that some of the cells at the edge would kind of have this papillary or micropapillary architecture, but I think I went with that focal area I thought looked like adrenal tissue.
What's this?
That is potentially some benign glandular structure. Can't say 100% I can recognize that.
Anna, what do you think?
That bit. I think that's appendix test.
Yeah, that's a testicular appendage remnant of the duct, with the Mullerian duct, or one of those. But yeah, the main lesion here is this ectopic adrenal rest. Okay, very common in this setting. You can also see some in association with ovaries. You don't want to call this a tumor. I think someone called it a Leydig cell tumor or something like that. You'll get into trouble. It's not a lesion, it's not a tumor. You should be able to recognize this as adrenal cortex at the very least. Remember, the adrenal cortex have got 3 layers: your zona granulosa, zona fasciculata, and zona reticularis, going from outside towards inside. And one layer is a bit clearer, then in the middle looks a bit acidic, and then gets a bit clearer again. And it's got all those sort of features, so ectopic adrenal rest. Okay, common thing, common site, but only if you know that it exists, otherwise you call it something else. Any questions? All good? This one is for you, man.
So would you say and testicular appendage, or you said that the duct there, or?
I guess I'm just noticing it now. When I reported it, I didn't see that testicular appendage, but now that both of them are there, why not mention both of them? But I put it there for that ectopic adrenal rest. Actually, before we get to you, okay, no, go on.
So this one, male with a fractal polyp. I call it well differentiated adenocarcinoma, arising from a tubular adenoma that had high-grade dysplasia, and I thought there was evidence by the cribriforming that we see widespread. And it's the butting, the resection margin that we can see. I thought I saw cellular invasion, vascular invasion as well, with the mucinous component, but that mucinous component was like less than 30%. I'm not sure if I should mention that at all. It's just a percentage. And I said plan for the testing, mismeasured patchy, BRAF and KRAS.
Neil, what did you think?
Well, I was a bit sort of haphazard on this. I didn't think it was a tubular adenoma. It sort of had a haphazard but a reasonably well circumscribed look to it. There are some cribriform areas, but then there are some glands that have like an apical snouting thing as well. Looking at it again, I probably wouldn't go the way that I went initially because the cribriform structures are a bit more prominent than what I put, which was like hydranoma papilliferum. But yeah, looking at it now, the cribriform structures strike me as a bit more of a feature, which you shouldn't have in hydranoma papilliferum. Yeah.
So what would you go with now?
So on a male with this pattern and all that cribriforming, I'll consider a metastasis first, and probably prostate adenocarcinoma will be my top one. And then, yeah, because it doesn't look like primary colorectal. There's no mucosal lesion. There's none of that dirty necrosis and sort of features there to make me think it's like primary colorectal. But I'll probably have prostate adenocarcinoma at the top of my differentials, given that cribriforming pattern.
Now you're talking. All right. But why were you thinking of how would hydranoma papilliferum end up here?
Well, I thought it could occur, yes, it is mainly a female vulvar thing, but it could happen anywhere in like the primary, like perianal region. So I thought potentially at low power it could have that appearance. It looked reasonably well circumscribed. Yeah, that's probably.
No, I wouldn't go there at all. I think you hadn't looked at it carefully. So I like this case. It's a very good case because it's one of those where, most people will agree it's an adenocarcinoma, but if you've got an eye for anatomical pathology, you'll be like, it doesn't look like the usual colorectal cancer. There's something about it that is not right for, adenocarcinomas that you normally see in this setting. Okay? That's actually important because once you get there and you're like, there's something not right about calling this adenocarcinoma. It's so unusual, the cribriform appearance, the fact that the lumina are empty. Usually colorectal cancers will have that so-called dirty necrosis in the lumen. It's and then you also notice that this tumor is actually coming from underneath and doesn't really reach the surface. And the epithelium on the surface, yes, it's a bit eroded here, but it's actually not dysplastic. You notice that? So it's actually sparing the surface. So most adenocarcinomas, they'll be arising from, from the setting of dysplasia. They will have an in situ component. This thing actually doesn't have an in situ component. So there's a number of things there that should make you think, oh, this is probably some metastasis or direct invasion of a carcinoma from elsewhere, just pushing into the rectum. All right. So what would you say? What would you do?
So I would do an NKX 3.1. Probably the most sensitive specific marker.
Okay. So this is NKX 3.1. It's even much clearer because you can see how it's sparing the surface. It's got nothing to do with what's at the top. Nice and diffusely positive. Same with PSAP, also nice and diffusely positive there. And your internal control being negative. And if you do your colorectal markers, I've got SAT-B2 here, negative in the tumor. It's positive on the overlying benign mucosa there. So this is prostatic adenocarcinoma. So it's a nice one.
Yeah, that's really good.
Yeah. It's just that subtle differences between the adenocarcinomas that you have to pick. And again, don't if you're going biased by the history of sigmoid polyp, you probably won't get to prostate. Okay, but if you're just looking at it carefully, just analyzing there, you will be like, so cribriform, it looks like prostate cancer.
But is it is it common for prostate adenoma to get like those sort of like apical snouting that I've seen in some other areas, or was I just
It's not. It's probably ductile. It's got a ductile look to it, which probably explains why it's got those snouting there. There's a bit of a ductile component to it.
Right.
I see what you mean, like these areas here. So the ductile being having these columnar cells, columnar cells, and phyloglandular architecture. That's ductile prostate adenocarcinoma there. Okay. Maybe a bit of this cribriform one is probably acinatine, and then these ones here as well, those elongated ones. This is all ductile adenocarcinoma here. Okay, so it's a mix of acino and ductile. If you want to be more specific, do you grade it? What grade would you give that?
I'll probably give it like a 4+4. Oh wait, because it's like metastatic, you don't grade it.
Yeah, we don't grade
We
it.
don't grade it
That's
because
actually
it's like eroded through the bowel.
it's a trick question. Don't grade that metastatic adenocarcinoma. Yeah, that's first week you got some surgical registrar sending a request to one of our pathologists, like, can you grade that metastatic carcinoma? Like, actually writing on paper, I was so pissed off. It's like, yeah, tell them off. This is another one as well, similar to the previous one. Common things in unusual sites, just trying to see whether they've got an eye for it without being biased by location and so forth. Rob, what did you call this?
Yeah, so it's a lymph node that's been replaced by this tumor that has papillary architecture. And you can see the cells are kind of, they've got nuclei which are hyperchromatic, indistinct, relatively indistinct nucleoli. Yeah, you can't really see them. I don't think there was any like foamy macrophages from memory.
They're way for me.
I don't think so.
Okay.
Did you see some?
Just look for them. Why would you be looking for foamy macrophage?
Oh, 'cause, some renal tumors. If it is renal,
Which one?
papillary renal cell carcinoma.
Right. Okay. Keep going. So.
Yeah, so you've got basically papillary neoplasm that's metastasized to the lymph node. So, I think you do like a panel of immunos. I was actually originally thought could it be like a papillary renal cell carcinoma, and so I had a panel to assess for that. Admittedly, it doesn't have the best morphology, but.
Rob, you give a lot of excuses. Don't give excuses for your shortcomings. You can't say it doesn't have the right morphology. For what? It's got the right morphology for what it's supposed to be. You just haven't gotten there yet. Yeah? I agree it's probably focally papillary here somewhere where it's sort of breaking down and you've got what looks like true fibrovascular cores there. But renal tumors do that once in a while. Even a good going clear cell renal cell carcinoma would have some papillary foci here and there if you look hard enough. Right. But then look more carefully at these cells here.
Yeah, I mean,
Okay.
for some people it could be. I mean,
No, not for some people. Well, there's distinct cell borders. Okay, it's eosinophilic. There's perinuclear halos. There's binucleation. There's nuclear wrinkling. What more do you need?
well, I guess it could be. It's probably best in keeping with a crow. eosinophilic variant.
Right.
And you can do immunohistochemistry to confirm
Nah,
that.
okay. So the expectation here was you say metastatic chromophore RCC or have it at the top of your list if you're going to give a differential. Can you include the history of previous nephrectomy, right? Yeah. So you gotta think, maybe something that came from the previous resected kidney. That's the clue in the history there. But this is a chromophore RCC. I don't have a differential.
Yeah, I mean, seeing it on the glass slide is a lot more clear, but you can't actually zoom in this much. But yeah, I agree, it looks pretty good for a chrom.
Yeah, it's a chromophore RCC. That's not a variant. Yeah, probably didn't look at it hard enough. So if you actually zoom in and actually start to look at it nicely like that, you will see those telltale signs, the irregular nuclei, perinuclear halos, bifurcation, and so forth.
Is that 40 times? You can only go to 20 times digitally. Not
And it's still blurry. It's still blurry at 20.
you can still see the
What about this?
membranes on the
Yes.
left.
Yeah.
Eosinophilic RCC, did you consider that as well?
Eosinophilic what?
Clear cell RCC.
Clear cell RCC.
Eosinophilic variant of clear cell.
How to consider it in the DDA?
If I give like a immunos.
Yeah, how as a DD, yes, but chromophore will have to be on top of that list. What immunos would you do to distinguish clear cell RCC from chromophore RCC?
You can do CK7 to be positive in chromophore and negative in clear cell. You can do CA9, CA9 IX, which should be positive in the clear cell and negative in the chromophore.
Let's start. Any other questions? Everyone got this far? Yeah, but this is one of those things that you have to watch out for exams. Seriously, common things in unusual science. Okay, it will be diagnostic, but if you start by reading the history and you get swayed and start to think of your own DDs in your mind, you won't get there. Yet the features of that lesion will be there. You just don't want to end up in the wrong path. Yeah. Okay.
But I agree with Rod, like the perinuclear clearing is much more obvious, at least to me, on a glass slide than the skin slide. And
I also agree with you there. If it was my decision, I think it was a bit premature for the college to start doing these exams digitally. One, because most labs don't have digital pathology yet, and secondly, the resolution is not there yet. So to be starting with glass slides and then you're given those digital slides, it's not the same. I struggle with QAP as well. Put something on QAP, like I can't tell what this is on this screen, but if it was on a glass slide in real life, I'll pick it like that. It's not the same. You guys will have to practice, digital reporting a little bit more, but then the resources are not there. So I think the college is not correct in doing that. Ali.
So we had, the stem was 85 male hernial sac, and we had mostly fibroadipose tissue, and there was a lot of like hemorrhage and granulation tissue, key inflammation. And then in the bottom fragment, in one area, all of a sudden, out of nowhere, there were all these signet ring cells. And then once I saw one, I saw heaps. So I said metastatic signet ring cell carcinoma and gave a DD and a panel of how I'd work out the primary. So that included colorectal, upper GI, urothelial, and then I did say lung and prostate, but these aren't normally signet ring cell morphology. And then I gave a panel of CK7, CK20, CDX2, GABA3, TTF1, PSA.
That is correct. That's good. That's as far as you can go on this. And the whole idea here is your eye for detail. Okay, if you didn't see these signet ring cells here, I'm not happy. I can't employ you as a pathologist in 3 years' time. Yeah, so there is a lot of inflammation and all this red herring, unintended, but you have to identify these cells as metastatic signet ring cells that are infiltrating there, and try to give some DDs and your liminals and say what you expect for each one of them and so forth, and get a full mark. This was metastatic urothelial. This guy comes back every few years with these biopsies that have got signet ring cell carcinoma from elsewhere, but his original primary was the bladder. Okay, so that's takeaway here. Your eye for detail. But look at that slide thoroughly. I'm sure you don't see anything, but at the same time, don't make up stuff. Shiva.
Accessory trace.
Accessory tragus. Yeah.
Yes.
Yep. Yep. Okay. It is. Something else?
Skin tag. Oh, I guess it's got collagen, so not really much needs.
Why is it not a choristoma or a teratoma?
Because it's too well organized, I guess, to be like a teratoma.
Yeah, that's probably a good argument there. In the site as well, these young people have got, this tiny little lump here. Earlier on, it's almost always this accessory tragus, which is the first brachial plate anomaly. Any questions there? So this is just a spoiler. You either know it or you don't. Okay. And if you know it, just the accessory tragus and move on. There's not much else to say. It can occur in a setting of a syndrome, Fractel and Golden Heart syndrome and so forth. But probably not, you don't really need to know that unless you do pediatric and perinatal pathology. Who's next? Sarah.
A 16-year-old male, scalp query inflammatory query tumor. So you got sections of skin to subcutis with a deep or well circumscribed nodule, spindle to stellate cells in short bundles and fascicles, looking a bit tissue culture-like. Pale nuclei, small nucleoli, bit of myxoid edematous background, some extravasation of erythrocytes. I thought this was nodular fasciitis, which you can do USB6 break apart fish to confirm. And I wasn't sure whether it included any DDs because I thought it was pretty good.
That's good. I totally agree. I can't add anything more. So it's got the characteristic features of nodular fasciitis. Okay. The right side like setting the patient edge of the skull. I've got the spindle cells, bit fascicular in areas, a bit haphazard, which is called tissue culture in appearance. Those lymphocytes and red blood cells in some of those microcystic spaces, myxoid stroma, also comes quite lesion. Is this a tumor or is it a reactive lesion?
I'm not sure of the exact answer. I would just be making it up.
Okay, that's fair enough. It's a very clever answer. Yeah, because we used to call them reactive, hence the term nodular fasciitis, because they tend to be self-limiting, so they go very fast in like 3 weeks. You know, this young person has got a lump here, and then if you don't do anything, it might regress in another few weeks. So it used to be called nodular fasciitis reactive, and then they discovered USP6 fusion, translocations in these tumors, and said, "Oh, it's now a neoplasia." Then people said, "Hang on, but it's a neoplasia, but then it regresses by itself." And then they say, "No, we'll call it a transient neoplasia." So it's a transient neoplasia. Yeah. All right. So yeah, nodular fasciitis. Any questions? Any issues there? Nice and straightforward. It's diagnosable. I had this in my part 1 in 2012. Just have to call it out right and we're good to go.
Should they do it
Spotter.
It's a spotter. I don't remember.
Parafelt.
Yeah, Rob, what do you call this?
Meningioma grade 1. It's got, meningoepithelial sort of spindle cells, nuclear pseudo-inclusion, swelling. I didn't see any brain invasion or my typical picture.
Subtype?
I don't usually subtype these, but you can say meningoepithelial. unless it grades changes the grade, of course. But you can say meningoepithelial.
You don't usually subtype your meningiomas.
Well,
I was told not to subtype in the exam.
No, I agree. I'm just laughing at the way you put it, that I don't usually subtype. You talk like you're a top opus or something. That's why I'm laughing. I don't subtype my meningiomas. How many? Okay, all right. Well,
But yeah, meningoepithelial.
yeah, grading is more important. So yes, you don't want to subtype them, but but you have to give me a grade, right?
Oh yeah, I said WHO. I said grade 1.
Yeah, no, that's fine. However, if you're going to subtype it, what is to call it?
Like meningoepithelial. It's got whorls. I can't see any other features of other subtypes.
Yeah, some areas look a bit fibrous to me. They're very spindle cell. Some areas, yes, it's got many motillial areas, but some of these surely say it's got a bit of bulk, isn't it?
That's why it does.
Yeah, like this one. Yeah, it doesn't have clinical significance. However, like a lot of these things, it helps you to recognize it. If you know that there are subtypes and what they look like, then it helps you. I'm sure you've seen some of those, the psammomatous and some of those weird-looking meningiomas. You just have to know the name, because if you don't go that far, you will miss it or you won't remember or know about it. That's why it's important. Okay. Yeah, meningioma. There's not much else to say there. We don't do any immunochemistry. If you're going to do immunochemistry, what do you expect of this?
It'll be positive for EMA, PR, and you could do somatostatin receptor 2A. which also be
And what will bump it up to grade 2?
Yes, there's a number of different criteria. So if my code count is like more than, I think it's 2.5 per millimeter squared. Millimeter squared. If there's any brain invasion, if it's clear cell or chordoid subtype.
Yeah.
Or if it has 3 or more of the sort of minor criteria, so like necrosis, small cell change, sheeting, and the like. Nuclear pseudos.
Okay. Yeah, you have to know the grading for your manager. That's important. You grade 1, 2, and 3 criteria and so forth. Now I did the molecular criteria as well, which I can't remember. Okay, let's move on. John, so what did you think?
So this is 16-year-old male lesion on ultrasound. So it showed us testes with multiple morphologies. So I thought it was at least a mixed germ cell tumor. In the corner, I thought it had a seminomatous area. Here, what you're showing looks a bit embryonal.
This one here?
Yeah. So I thought that was a seminoma. I thought there was an embryonal area, and perhaps a yolk sac area as well. Some more myxoid. But I looked in the hemorrhage trying to look for chorea, but I didn't really see any obvious morphologies that look like chorea to me. And I looked for teratomatous elements, which I didn't see clearly. So I called it mixed germ cell with those 3, and I'll extensively section and examine more sections.
What this area here?
This area here, it's myxoid stroma, hemorrhage in the center, some tubules. Okay, so tubules. They don't look that immature, but I guess they probably shouldn't be there. Is that you suggesting that's a teratomatous element?
I think so. It's probably one of those where you do, even though to make sure it's not any a yolk sac component.
Yeah, I just thought it was like it fit more with.
Yeah, this is teratomas in other slides. I wasn't planning to put a teratomatous component here, but there it is. Some yolk sac intermixed with embryonal areas like this one here. But yeah, I agree with you, mixed germ cell tumor. What are the things that you are expected to mention when you are reporting these?
And you're meant to put the percentages.
Yeah.
I guess you meant to say what components each compose of the total tumor.
Yeah.
And
What else?
I guess the size, and then especially if there's immature elements, if you do have a teratoma. You comment on GCNIS, which you expect to have. Lymphobacterial invasion, if you see it.
Yep.
If it invades through the rete testis into the
Extend of
extends.
tumors or both.
yeah,
It branches.
margin.
Okay. Yeah, no, that's good. Yeah, so the reason for putting this is to make sure that you can identify the different components, particularly the seminoma, which for some reason, I don't know why people fail to recognize seminoma. I find it the easiest one to pick, the commonest. So there's a good going seminoma component here, embryonal, a bit of yolk sac between some of those embryonal there. I agree with you, there's nothing to suggest choriocarcinoma here. Okay. Any other questions? Anything different? Nice and straightforward. All right. Couple of bonus ones, just because. A bit difficult though. Ali.
Okay, so it's a section of soft tissue. There is a cellular area, and then there was also a fatty area with a kind of a more less cellular component. In this area, there are atypical spindle cells that stand out. They're very hyperchromatic. And then adjacent to it, the fat is kind of a ball bearing different sizes. And I thought I saw like very focal lacriblast. And then immediately next to that, there was that more cellular area where it was quite a sclerotic background and a lot of the atypical spindle cells and no more fat. So in this site and age, I was worried about a D-diff liposarcoma, and I said I would do an MDM2 fish to confirm that.
That's good. I think that's a straightforward pass. Yeah, so you're expected to recognize that this is not normal fat. A lot of variation in lipocytic sizes. There's some atypia, some of those spindle cells. And then you get that abrupt transition into an area that's more cellular with more atypia, which will be the differentiated component of this tumor. If you know enough about tumors of the paratestis, this is the commonest sarcoma that you find in the spermatic cord in the paratesticular area. So it's a common tumor in its usual site. And that's enough for you to be able to call it outright, or at least have differentiated liposarcoma on top of the differentials here. Can't think of a differential. Can someone think of any? Can't think of any.
I said if the MDM2 fish was negative, I guess I'd have to consider some other sarcoma coming into the liposarcoma.
I'll fire the person who did the fish. It has to be positive.
No, so I don't know what I would do then.
Yeah. I mean, the fish doesn't always has to be positive for a number of reasons. So, but that's on morphology alone. That's enough to call it. I don't have a differential there. Last one. Shiva.
So we have a high-grade lesion, which is showing various architectures, sheets, papillae, long areas, and so these are sheets, densely cellular and atypical with significant bizarre mitoses as well, I think. This one, I'm not sure. But there's areas where they're snouted as well, hobnailing, and quite pleomorphic. And so there's lots of cell clearing, like clear cell change. So I thought that was most consistent with a clear cell carcinoma.
Okay, I agree. A little benign polyp, just to come with it. But yeah, clear cell carcinoma is the favorite diagnosis in this one, based on morphology. It does have some areas where you start to wonder whether it's an adenocarcinoma, endometrial adenocarcinoma. So if you have that in your DD, or you probably struggle to tell whether it's clear cell or endometrioid, that is completely acceptable. Okay? In fact, the resection after this came with a little bit of endometrioid as well as clear cell areas. that's it. Any questions, any comments?
For this question, what parts look endometrioid? Just so I can get my eye.